All right, a very pleasant welcome to one and all for another wonderful session of academic radiology education program here. Myself is Dr. Janardana Panatapura, one of the cardiothoracic radiologists at Wake Forest University School of Medicine. And I welcome you all. Just before we start, I wanted to just give a very brief introduction about AREP for the folks who are joining for the first time. The Global Academic Radiology Education Program is a nonprofit initiative aimed at providing high-quality radiology educations to colleagues worldwide. This was established in October 2021 and based at the Department of Radiology at Wake Forest University School of Medicine. This offers free online educational resources and live webinar featuring academic radiologists from leading U.S. institutions. This program is designed to bridge educational gaps, which is particularly for radiologists in resource-limited settings by sharing expertise and fostering global collaboration. So we host bi-monthly webinars from January to October typically and covering various radiology subspecialties. These are very well attended and includes contributions from esteemed institutes. It extends to radiologists in different countries in Asia, Africa, and Middle East. And this program's success is driven by the dedication of its committees, moderators, and speakers who work tirelessly without external funding. In addition to webinars, we also offer some radiology excellency program and focus on mentoring and specialized radiology challenges in various countries. So with that, and welcome for another great session, and this on MRI staging of endometrial and cervical cancers, the FIGO classification, and by our speaker, who's well known to us, Dr. Venkateshwar Surabi. He's a professor in abdominal imaging at the University of Texas MD Anderson Cancer Center and McGovern Medical School at UT Health. He is a distinguished educator, researcher, and clinician. He has made significant contributions to oncology imaging, and his particular interest in hepatocellular carcinoma, rectal cancers, and advanced abdominal imaging techniques. So Dr. Surabi has authorized numerous and peer-reviewed publications. He has served as reviewers for leading radiology journals and delivered invited lectures at major national and international radiology societies, including at the RSNA, ARRS, and Society of Abdominal Radiology. His leadership in liver imaging, development of LIRADS protocols, and mentorship of trainees reflects his commitment to advancing abdominal radiology and improving cancer care. So now I welcome Dr. Surabi. Welcome for this great session, and the stage is yours, sir. Thank you.
Thank you so much, Dr. JP, for a kind introduction. And hello, everyone. Let me share my screen here 1 second. You can see my screen, right?
Correct.
Perfect. Okay, I'll get started. Hello again. So today's topic is MRI of endometrial and cervical carcinoma, FIGO staging, and as well as touch base on how MRI can improve and guide management of these cancers. I have nothing to disclose. Primary objectives for today's 1 second. Let me minimize the side window. Yeah, MR imaging findings corresponding to the FIGO staging of endometrial and cervical cancer, pearls and pitfalls of staging, and also highlighting the added value of MR in the treatment stratification of these malignancies. So imaging plays an important role in the evaluation of disease extent and treatment planning in endometrial and as well as cervical cancer. We all know ultrasound and CT have limitations when it comes to evaluation of endometrial and cervical carcinoma staging, and hence MR plays an important role from an initial evaluation to delineating the extent of the disease to appropriate treatment selection and as well as follow-up of these patients. Just touch base briefly on the MRI technique. High spatial resolution, sagittal, coronal, and axial oblique T2 weighted images plays really critical role. Dynamic contrast enhanced imaging we routinely use for endometrial carcinoma, and it can be useful for in difficult cases in the detection of the depth of the myometrial invasion, but it has not much role in cervical carcinoma staging protocol because the T2 weighted images give the answer. DWA imaging diffusion weighted is routinely used and of course is useful, and as well as some centers do high spatial resolution fat suppressed T1 weighted images. And then it is key to get a true axial oblique image, similar to the rectal cancer protocol, so that we can accurately assess the parametrial invasion and as well as the depth of the invasion into the myometrium. And that is the axial oblique image obtained by, perpendicular to the axis, longitudinal axis of the tumor, as shown here, rather than the, axial image of the anatomical pelvis, and hence there is no partial voluming effect, particularly in assessment of depth of myometrial invasion or parametrial invasion. Cervical cancer is the second most common cancer in women worldwide. Peak incidence is between 30 and 40 years of age, and the FIGO staging of cervical carcinoma is clinical. Of course, it does not rely on surgical or pathological findings, but MR plays a critical role. I'm going to show some examples. The FIGO staging, just to touch briefly, stage 1 is divided into 1A, 1A1, 1A2. When the invasive carcinoma can be diagnosed only with the microscopy and the tumor is not seen on MR imaging, that would be 1A1 or 1A2, depending upon the pathological depth of invasion. 1B1 is when there is clinically visible tumor, but less than 2 centimeter, 2 to 4, or more than 4, 1B1, 1B2, and 1B3. And then 2A is when the tumor involves the upper vaginal canal or parametrial extension. And then 3, when tumor extends to, either lower third of the vagina or extension to the pelvic side wall in the form of, hydrourethronephrosis or ureteric involvement. And then, there's new additions based on the 3C involvement of the pelvic or paratic lymphadenopathy. And stage 4 is based on, A is based on involvement of the adjacent organs like urinary bladder or rectum, whereas B is distant metastasis. So the most important aspects of the cervical cancer imaging is one, assessment of the tumor size, second, assessment for parametrial invasion, and third, assessment for adjacent organ involvement in the pelvis in the form of either urinary bladder or sigmoid colonic involvement. And then there are several studies that have shown that MRI tumor size assessment or accuracy is 90%, whereas clinical exam under anesthesia accuracy is only 60%. And hence all this staging, FIGO staging, clearly depends, the stage depends on the tumor size. So obviously MR has a significant role compared to clinical examination alone. And then coming to the parametrial invasion, again, the negative predictive value of MR is 90 to 100%, whereas clinical examination is only 29 to 74%. So there is wide variation with the clinical examination in assessment of the parametrial invasion. Again, very important factor in treatment and management of these tumors. And then, of course, for assessment of bladder invasion or sigmoid colonic invasion, if there's no invasion on MR, the negative predictive value is 100% really. And then, the clinical examination cystoscopy and sigmoidoscopy, invasive techniques, and it's positive only in less than 5%. So, we're, way more invasive for amount of prevalence of invasion of the bladder and sigmoid colon. So MR clearly plays a significant role in assessment of these 3 key parameters that can decide the management of the cervical carcinoma. So let's see some examples here. This is a biopsy-proven cervical carcinoma. Obviously, an MR, good quality exam. There's absolutely no abnormality. We don't see any mass. This would be consistent with the FIGO 1A, meaning it's biopsy-proven, but we do not see any macroscopic disease or, MR evident disease on pelvic exam. Moving to the next example here, that we can see on the images, there is a mass lesion extending at the external os of the cervix, and this is 1B1 based on the size of the tumor. Now moving to the next stage, which is more than 2 centimeters, but less than 4 centimeters. Again, tumor extending exophytically from the external os into the vaginal canal. But again, in this patient, we have given vaginal gel, but there is no involvement of the vaginal wall, and hence it would be 1B2 based on the size criteria alone. So again, as I showed, there are multiple studies. There's a study published with 71 patients, tumor size within 5 millimeter in 93% of the cases. Another study published showing that in 151 surgically treated patients, the mean difference between MRI and histological pathological size measurement was within 0.9 millimeters. So again, MR has proven in this regard for accurate assessment of the tumor size. Moving to the next stage, FIGO 2A2, here we can see there is exophytic mass arising from the cervix, extending into the vaginal canal. But in this case, we can see the anterior wall of the vaginal, upper third of the vaginal wall is involved, right? Unlike the other case where you could see the vaginal gel going all around the tumor, but in this case, there is a tumor involving the vaginal wall, making it FIGO stage 2A2. A roll of vaginal gel, again, with gel may be useful, particularly in the tumors like this, where tumor extends into the vaginal canal, and you want to make sure that there is actual involvement of the vaginal wall versus just tumor, sitting within the vagina. It can help. In that regard, actually, physical examination is generally very reliable for assessment of the vaginal extension. It's not an invasive technique; they can easily assess. So it's optional. We do use it at our center, but vaginal opacification remains optional. Moving to the next criteria, parametrial extension. So parametrial extension is identified by disruption of the low signal intensity outer ring on T2 weighted images. Of course, with the additional findings of speculated tumor to parametrium interface or if clear-cut soft tissue extension or encasement of the periuterine vessels. And some studies have shown that if we have intact low signal intensity stromal rim of the cervix greater than 3 millimeters, that virtually excludes any parametrial invasion. So let's look at some examples here. So there is a cervical tumor, large tumor, circumferential, and in this case, we can see, the outer hypointense layer is lost, and we can see these tumor speculations extending into the parametrium. Very evident case. It's not subtle at all. So this is consistent with parametrial invasion, FIGO stage 2B. And this is surgically proven. There was no evidence of parametrial invasion. So here we can see this hypointense layer is maintained on the left side. Right side, it's maintained on the majority of the aspect. And then we can see here, there is no tumor speculations at all. There's a clean outline as well as on diffusion weighted images. So this turned out to be there is no evidence of parametrial invasion, although the 3 millimeter hypointense layer is not maintained focally on the right side, but lack of speculations in the parametrium, very clean parametrium, helped in this case to call it as negative parametrial invasion. Sometimes, MR, there can be pitfalls for assessment of parametrial invasion, particularly in large tumors. It can cause a lot of edema and also increased vascularity at the base of the tumor that can look like, parametrial invasion on imaging. So, yes, it's not 100% accurate. Here is an example here on T2 weighted images. This is actually proved to be no parametrial invasion. So on T2 weighted images, we can see on the left side, there is hypointense stromal ring is maintained, but on the right side, the stromal ring is slightly thinned out. But we do see a little bit of defined outline here, post-contrast images, some, increased vascularity, so kind of equivocal, but turn out to be no parametrial invasion. So we have to be careful whenever there is a lot of vascularity in the parametrium. We have to really not use any dynamic images and just focus on T2 weighted images for any actual tumor signal extending into the parametrium. This is another case of negative parametrial invasion. In this case, we can be very confident on T2 weighted images because the hypointense stromal ring is maintained all around. But you can see how, the increased vascularity in the parametrium, if you do not use this sign, can easily, can mimic or can confuse the, the readers to suspect parametrial invasion. So this is a case of no evidence of parametrial invasion based on the maintained hypointense stromal ring. Moving on to some advanced cases here, obviously, we can see a large tumor in the cervix extending into the parametrium, and as well as extending to the, encasing the ureters. Here, you can see the left ureter, right ureter is being encased here. So this is the pelvic side wall extension case, leading to encasement. And of course, we can also see some lymphadenopathy in the pelvic side wall in this particular patient. And this is a patient with the invasion of the urinary bladder base, again, large tumor, large parametrial extension, involvement of the uterus, and as well as urinary bladder. So that's for the cervical cancer. Now moving on to the endometrial cancer staging. So endometrial cancer is the most commonly diagnosed gynecological malignancy in developed countries. And clinical staging is inaccurate. FIGO developed a surgical pathological staging system for endometrial carcinoma. And MR imaging is not part of the FIGO staging system, but again, it plays a critical role. Most of the clinicians, they use MRI before taking patients to surgery. So all patients with endometrial cancer undergo surgery as a primary treatment. And based on the surgical findings, based on the histology, based on the whether there was lymphovascular invasion is present or not, the FIGO staging system staging is determined. But according to the full FIGO staging, consists of a total abdominal hysterectomy, bilateral salpingo-oophorectomy, peritoneal washings, retroperitoneal lymph node dissection. But surgeons do not want to do this such a radical surgery in all patients, and hence MRI used to see how much surgery they need to do. The extent of surgical resection is determined based on the preoperative MRI, and hence MRI plays a critical role in endometrial cancer management as well. So for learning objectives for the endometrial cancer aspect, so there's actually a new classification, updates to the FIGO system in 2023. And I will review that FIGO staging system and review of some of newer molecular and pathological advances, and using imaging findings to see how imaging can fit in with these FIGO updates in 2023, and of course, touch base on some novel treatments and role of imaging. So again, endometrial cancer is the most common gynecological cancer in the US and Europe with increasing incidence. It is surgically staged according to FIGO. And there are really significant advances in understanding the biology of the endometrial cancer based on the pathology and molecular classifications. And that led to the 2023 revision of the FIGO staging system. And this update added new risk stratification based on molecular and genetic findings, and then histological subtypes, grade, lymphovascular invasion. All these are incorporated into the FIGO staging system. So it's a much complex system than the cervical FIGO staging system. But this really incorporates a lot of molecular subtypes that can be targeted with the newer available agents. And again, to indicate imaging is not part of the FIGO staging system, but plays an integral role in assessing extent of surgical resection, meaning tailoring treatment. And again, based on the histology, imaging with CT, chest, abdomen, pelvis, PET-CT also play an important role in assessment of complete staging of the endometrial cancer. And tumor characteristics on pelvic MRI, such as tumor size, degree of diffusion restriction, whether there was any peritoneal disease in the pelvis. And there are many studies looking at the ADC values, degree of contrast enhancement in predicting the histology, grade, lymphovascular invasion, molecular subtype in selecting patients. But that work is still investigational, and still a lot of work needs to be done before we can come up with strict guidelines of if we see this much of diffusion restriction, it could indicate a particular subtype. That work needs to be done. So new FIGO staging system. So obviously it adapted the binary tumor grading approach. So it's graded into high and low grade. That's one. And then two histological subgroups, aggressive and non-aggressive, based on the histopathology. And now it incorporates the some of the molecular subtypes like pole mutation, MMR deficient, P53 are no specific molecular pattern. So there are 4 patterns based on the molecular subtyping. And also, this 2023 update also subdivided the lymphovascular invasion to less than 5 versus more than 5 vessel involvement, describing as focal versus substantial. And also, they expanded to include nodal involvement based on metastatic tumor size, and new subdivisions are also added. And it's a complex system, so let's look at it, one by one. So endometrial cancer is divided into low grade and high grade. Low grade, grade 1, 2, that's all based on the non-glandular growth pattern. So that's histology. We don't have to, worry or know much about this, because this is provided based on the histopathology after the resecting the tumor. But in terms of the histopathological subtypes, endometrioid carcinoma is considered grade 1 and grade 2. Aggressive histological type is any other type of endometrial carcinoma, such as either serous, clear cell, mixed carcinosarcoma, undifferentiated carcinoma, or gastrointestinal type. These are all considered aggressive histological type. And of course, also a grade 3 endometrioid carcinoma is also considered as aggressive histological type. So according to the histological subtype, it's divided into non-aggressive and aggressive, and this is the paradigm of how this chart is used. And then for the lymphovascular invasion, it's again according to the new classification, it's divided into either absent versus focal, if it's less than 5 vessels, and then more than 5 vessels. Again, this is histological assessment and not done on imaging. But what we can do on imaging is the next aspect, which is the myometrial invasion, which is relevant to FIGO staging system. And it's divided into whether there is no myometrial invasion, as in this case here, where we can see kind of a polypid tumor with maintained junctional zone and no abnormality at the interface, versus, in this particular case, we can see there's kind of, focally, there is a fluid all around the tumor, but focally there is ill-defined outline. But again, when you measure to the complete thickness of the myometrium, this is less than 50%. So the less than 50% versus another case where, there is clear-cut myometrial invasion, and then, the spared myometrium compared to entire thickness of the myometrium is less than 50%. So that would make it more than 50% of the invasion by the tumor. So based on the molecular prognostic groups, again, irrespective of the histological type or lymphovascular invasion, early stage endometrial cancers 1 and 2 are again subdivided based on the molecular subtypes. So there are good prognostic groups with a pole mutation. If there is a pole mutation, that is considered good prognosis. Whereas intermediate prognostic group is where there is mismatch repair deficiency or non-specific molecular profile. And obviously, if there is a P53 molecular abnormality, that would be poor prognostic group. So for tumors that are stage 1 and 2, FIGO stages can be downstaged to stage 1A if associated with pole mutation. This is a very, recent advance based using the molecular subtype of the tumor. And we know these tumors behave, and prognosis is much better than tumors with P53 mutation and can be downgraded to stage 1A. And also, if there is a P53 mutation, they are upstaged to 2C to take into consideration of, not just imaging, not just histology of these tumors, but also looking at the molecular profile of the tumor. And staging is not affected for intermediate risk molecular profile, such as either MMR deficient or non-specific molecular profile tumors. Of course, but if it's already FIGO stage 3 or 4, the molecular profile has no role, meaning there is no upgrade or downgrade based on the molecular profile. Of course, but the even stage 3 and 4 cases, molecular profile is useful for, targeting, targeted therapies, immunotherapies. So, just to show, some examples here, molecular classification. This is endometrioid type of endometrial carcinoma. Obviously there's metastatic lesion. This is MMR deficient tumor. This is example of a non-specific molecular profile. Just again, this is on histology, not based on the imaging, but I'm just showing examples of a pathologically, proven or subclassified based on the molecular subprofile. And this is an example or case that turned out to have a p53 abnormality. So let's look at it again. So stage 1, FIGO 2023, tumor is confined to the uterus and ovary. That's again interesting aspect. I'm going to show some details. So before we look into this, actually, let's go ahead and take a look at these images here. So we have a stage 1A1, where there is tumor without any myometrial invasion. That is stage 1A1. So non-aggressive histological type, that is, again, it's important to know histology, whether it's aggressive or non-aggressive, meaning it has to be endometrial type to be non-aggressive histological type. And it's confined to the endometrium, no myometrial invasion, then it would be stage 1A1. Stage 1A2 is non-aggressive histological type, again, no lymphovascular space invasion, and myometrial invasion less than 50%. So of these, we can only assess myometrial invasion on imaging, right? Lymphovascular invasion is based on the, resected specimen, right? Hysterectomy. So, the staging really, incorporates the resecting the specimen and diagnosing. But then on imaging, if we see a lesion here, obviously they will have a biopsy. So we would know whether histological type, whether it's aggressive or non-aggressive based on whether it's a clear cell, then that would become aggressive, or a grade 3 endometrial would become aggressive. But if you have a, grade 1 or 2 endometrial, that is non-aggressive histology, and in imaging, if you have less than 50% myometrial invasion, we could say most likely 1A2, but obviously it requires a pathological confirmation of status of the lymphovascular invasion for final FIGO staging. And then there is this new concept of 1A3, where again, non-aggressive histological type, no lymphovascular invasion, myometrial invasion less than 50%, but then isolated ovarian metastatic lesion to one ovary, that would be still considered 1A3 rather than consider it as a metastatic disease. Moving on to the next types, 1B is when there is myometrial invasion more than 50%. So it's again, non-aggressive histological type, no lymphovascular space invasion, but myometrial invasion more than 50%. Whereas 1C is aggressive histological type, confined polyp to the endometrium, no myometrial invasion, but based on the aggressive histological type. So on biopsy, if we see a grade 3 endometrial carcinoma, or some of the other variants like clear cell variant and all, that would be considered 1C. So now if we go back, now it makes much more sense. So that's what this chart is showing. So the FIGO stage 1 is based on histology. So we need to know what kind of tumor it is. We need to know myometrial invasion, which is done based on MR imaging. And of course, we need to know the lymphovascular space invasion. And this new concept of ovarian invasion is allowed. First of all, it has to be a low-grade endometrial type. There should not be any myometrial invasion, no lymphovascular space invasion. It has to be unilateral ovarian deposit limited to ovary, and no rupture or capsular involvement of the ovary. So it just isolated ovarian met, that would be considered stage 1A3 for low non-aggressive types. I know there's a lot of information, but that's what 2023 update is. So we're just trying to make sense of what has been updated. So when coming to the stage 2, again, let's look at this chart, which gives much more information. So non-aggressive tumors, again, histology we need to know, with cervical stroma or lymphovascular space invasion, or aggressive tumors with any myometrial invasion. So again, we need to know the histology of the tumor. and based on that, it can be divided. So if you have aggressive histological type, any myometrial invasion would become stage 2C. If you have a non-aggressive histology, invasion of the cervical stroma would be 2A, and then non-aggressive histology, but substantial lymphovascular invasion, any myometrial invasion, but if there is a presence of lymphovascular space, that would be 2B. So here is an example of a cervical stromal invasion. So there is a large tumor replacing the endometrial canal, and there is extension into the cervical canal. And just prolapsing into the cervical canal is not enough. We need to see actual invasion of the cervical stroma. And you can see here loss of this inner hypointense layer and tumor extension into the cervix, consistent of cervical stromal invasion, which would make the tumor 2A if you know the histology as a non-aggressive tumor. And that's what this chart is showing. So any cervical stromal involvement or substantial lymphovascular invasion. Now moving on to the stage 3. So again, stage 3, tumor of any histological type with the local or regional spread. So let's take a look at it. What does that mean? So 3A1 is spread to ovary or fallopian tube. Of course, except we addressed the special category of 1A3. So barring that special category, if any other histology, tumor spread to ovary or fallopian tube would be 3A1. Uterine serosa, there is another concept of the tumor involving the entire thickness of the myometrium and reaching the uterine serosa, that would be stage 3A2. Only if there is a metastasis to the pelvic peritoneum without any metastasis to the abdominal peritoneum, that would be stage 3B2. And spread to the vagina or parametrium would be 3B1. And also based on the local and regional spread, the 3 is based on if there is 3C1, if there is only metastatic disease to pelvic lymph nodes, and 3C2, if there is lymphadenopathy involving the para-aortic region. And of course, 4 is, little straightforward. 4A is involvement of the bladder or bowel, meaning either urinary bladder or rectum or sigmoid colon. Stage 4B is peritoneal metastasis beyond pelvis, and stage 4C is distant metastasis, talking about liver or mediastinal lymphadenopathy or bone, brain, or pulmonary metastatic lesions. That would be considered stage 4C. So just to again show, stage 4A is bladder or bowel mucosal involvement. 4B is just beyond pelvis peritoneal metastasis, and 4C is distant metastatic disease other than the peritoneum. So for role of imaging, so it's of course FIGO update supports more integrated multidisciplinary approach. As we can see, there is input from histology, clearly based on the tumor type, tumor aggression, and as well as lymphovascular space invasion. But also it incorporates MRI in terms of myometrial invasion, in terms of assessment of the lymph nodes, peritoneum, or distant disease. So radiologists play a pivotal role in decision-making related to management of these patients. And any patient who is presenting with abnormal uterine bleeding, obviously, initial investigation is transvaginal pelvic ultrasound to assess, endometrial thickness, or if there is any focal polypoid lesion, followed by next would be, MRI. Typically, MRI is done after, they do biopsy of the endometrium or they resect the polyp and that turned out to be a cancer. Then they would do MRI to see the extent of the disease, right? MRI can stage from stage 1 to stage 3 once you have histological type. And then depending upon whether aggressive or non-aggressive type, one can use CT, thoracic, abdomen, and pelvis, and as well as PET-CT for further staging of this disease. So just to show some examples again, the most important aspect that we can provide to the surgeon is myometrial invasion on MRI. Let's look at some examples. So there is again a polypoid mass lesion within the endometrial canal. There is no evidence of any invasion into the junctional zone or disruption or irregularity. So this would be no myometrial invasion. This would be a less than 50% of focal myometrial invasion. Again, less than 50% of the focal myometrial invasion here. This is a case of a myometrial invasion, but again, less than 50%, much more obvious than the other focal cases. And of course, this is more than 50% myometrial invasion, where the tumor is clearly going, involving more than 50% thickness. And you can the way you can measure myometrial thickness is you can look at where the maximum myometrial invasion is and measure the entire thickness of the myometrium in that location, measure the depth of the tumor, and see whether it's 50% or more. Again, cervical stromal involvement. So it is again very important to know that just extension into the cervical canal is not cervical stromal invasion. So we need to see actual tumor going into the cervical stroma, meaning you should see loss of this inner hypointense layer. So in this particular case, the tumor is protruding into the canal. It looks the hypointense layer is maintained. Again, you can see there is no, irregular wall, tumor, and cervical interface is very clean and smooth. And that is confirmed on post-contrast images as well. So this is not considered cervical stromal invasions. To call it a cervical stromal invasion, we need to actually see the tumor going into the cervical stroma as seen in these two cases here, where there is the tumor and cervical interface is irregular, and then the inner hypointense layer is disrupted. Lymph nodal disease, again, that is stage 3C. In this particular case, you can see, lymphadenopathy here in the pelvic side wall, bulky lymph nodes, bilateral, and of course, higher up, in the image portion, you can see the retroperitoneal lymphadenopathy as well. Stage 4, extensive pelvic disease. Sometimes, obviously, when it comes to stage 4 disease, other than limited to the pelvis, would depend on, staging CT, chest, abdomen, pelvis, and PET CT for accurate staging. But if it's just limited to the pelvis, such as, just direct extension to the bladder or rectum, or just a pelvic peritoneum, then MR can play a role. And also assessment of the tumor response, post-treatment images and comparing with the pre-treatment. Yeah, obviously, typically, it's resected, and then when we are assessing treatment responses for recurrent cases. So if there is a recurrence involving the vaginal, vault, obviously we would see, loss of intermediate T2 signal intensity and tumor becoming more fibrotic, meaning it becomes more hypointense, loss of diffusion restriction over a period of time, loss of enhancement. Those are the things like any other tumor that we use. We would use it for endometrial cancer as well. So just to look at the advantages and challenges of this newer classification. So advantages, obviously, it incorporates the molecular subtyping, and then, there are multiple, subclassifications in line with the tumor heterogeneity and behavior of the tumor. So accounts for different types of uterine and exuterine cancer spread. It helps accrue accurate data and hence prognostication, therapeutic significance. It includes the nodal involvement based on the tumor size. And also, synchronous involvement of the uterus and ovary with the defined parameters also helps to avoid over-treatment of some of these tumors. Challenges, multiple parameters are included. Basically, you need to have MR, clinical, molecular profile. You go into minute details of, lymphovascular invasion, but like, is it less than 5, more than 5? The uterine myometrial thickness, is it going all the way to the uterine serosa? It complicates ongoing research because it's all based on the older system, FIGO staging system. And there's some criticism about lack of consultation with pathology community when it comes to, coming up with this FIGO staging system. There are some studies that have been ongoing, looking at, can MR predict lymphovascular space invasion using tumor size cutoff of 3 centimeters. And also there are a lot of studies that are being done to look at the ADC values and determine whether, that can predict it aggressive versus non-aggressive histological type. But that's still investigational. Nothing concrete to say that, okay, if you see ADC value of less than 800, that would indicate aggressive histology. We are not there yet. A little bit regarding the impact of the molecular profiles. Pole mutation, again, it's very good prognosis. Non-specific molecular subtype is intermediate. P53 is poor prognostic indicator, and again, MMR deficient tumors are intermediate prognostic types. Let's look at some examples here. So again, MR can, risk stratify based on the depth of myometrial invasion that can be given accurately, and as well as presence of cervical stromal invasion can be given. So let's take a look at some examples here. So depth of the tumor invasion. So, sometimes I found it actually dynamic post-contrast images can be very useful, particularly on T2 where, yes, it appears little ill-defined here, but on post-contrast, you can see the anterior wall is smooth and there is irregular outline between the tumor and the myometrium. And that's where, and the dynamic post-contrast images definitely have a role in endometrial staging. In this case, it is less than 50% invasion. And again, as I reiterated before, cervical stromal invasion is important to identify, not just extension into the cervical canal. Again, with the C-section scars also, we need to be very important to look at and not call that as cervical stromal invasion. So we need to again look at, interface of the tumor and the stroma. If it's typically, if there is invasion, you would see irregular interface. If it's a smooth interface like this, there is no tumor invasion of the stroma. It's just prolapsing tumor into the canal. And again, this is a patient where there's full thickness myometrial invasion, but also you can see the tumor going into the level of the uterine serosa. So that's another important aspect to identify because it puts the tumor at a higher level. This is an example of endometrial cancer with parametrial extension. Again, we can use the same principles as that of the cervical cancer parametrial invasion criteria, whether we see loss of hypointense layer and tumor speculations extending into the parametry. There are some pitfalls that can happen, particularly with the large, kind of bulky polypoid tumors in the endometrium, and that can really thin the myometrial thickness. But again, we have to, critically look at the dynamic post-contrast images to look for any irregularity of the tumor and myometrial interface to decide. If it's smooth, there is no invasion. But again, if it's thin, then if there was myometrial invasion, it can be difficult really to see whether it's less than 50 or more than 50%. Sometimes if there is underlying adenomyosis, in this particular case, actually there was underlying adenomyosis as well. But again, in those cases, diffusion weighted can help to differentiate sometimes the actual tumor versus adenomyosis. So sometimes, T2 may not be that helpful in the background of the adenomyosis. We have to use, dynamic post-contrast and diffusion. And at least in our practice, we found that diffusion is helpful in some difficult cases, particularly with the underlying adenomyosis, to decide, hey, where is the adenomyosis, where is the tumor? So depth of myometrial invasion can be accurately done. And again, some DWI and dynamic contrast images increase the accuracy. Delays phase enhancement of cervical mucosa excludes cervical stromal invasion. There are some pitfalls, particularly polypoid tumors compressing, adenomyosis, if there's uterine fibroids, and also under and overestimation of the depth of the invasion at the carnua, because already the myometrium is so thinned. Sometimes, in DCE, there is peritumoral enhancement can make the overestimation of depth of invasion. But again, if you use the irregular interface sign, it can be very useful. Again, of course, all useful in assessment of recurrence. 15% of patients ultimately develop recurrent disease. 87% experience recurrence within 3 years. Most common sites are actually pelvic lymph nodes and vaginal vault, and hence, again, local staging can have a significant role in detection. This is an example of a recurrence after hysterectomy within the vaginal wall with the intermediate signal intensity tumor showing diffusion restriction as well. Just to conclude, so advances in understanding the pathology and molecular classification of endometrial cancer have led to revisions of the FIGO staging system, and it adds new risk stratification based on updated molecular and genetic findings that change management decisions. Histological subtypes, grading, lymphovascular invasion, molecular subtypes, and disease extent, which is decided based on MRI, are essential elements in the FIGO staging system. The imaging is not part of the FIGO staging system, but plays an integral role in preoperative assessment, which is crucial to tailor treatment. And of course, myometrial invasion, depth of invasion can be given. Um, and tumor size, degree of diffusion restriction, peritoneal implants, contrast enhance may help predict tumor histology, grade lymphovascular invasion, but work still needs to be done. And select imaging findings, have potential for diagnostic and management implications. With that, thank you so much. And I can take any questions now.
Dr. Surabhi, thank you so much for such a wonderful illustrated. The images were excellent, and I learned something new. Thank you so much.
Thank you.
Okay, let's see if I have some questions here. All right, we have a question for the endometrial cancer. It is if it diffusely fills in the endometrial cavity, obscuring inner surface of the junctional zone, how can we clearly evaluate myometrial invasion percentage? Thank you.
So that is actually a very good question, and we struggle, day-to-day practice. But I rely on the dynamic post-contrast images and the tumor and the myometrial interface. If it's smooth, there's probably no invasion. If there is any irregularity of that interface, as I've shown in some examples on dynamic post-contrast or as well as on delayed phase images, I think that's where we have to look at the interface, whether it's smooth versus irregular. If it's irregular interface, then we would call it as invasion.
Great, thank you. Next question. How often we come across fungating lesion at internal os? How do we determine whether it is endometrial cancer extending to the cervix or vice versa?
That is actually a great question. Yeah, it's difficult on imaging if it's a large tumor, going up into the endometrium, where they originated in the cervix versus vice versa. I know there are some literature published based on the where is the epicenter of the tumor, but it is and most of the times histology is available by the time is you see MR for endometrial and cervical carcinoma is done as a staging tool after histological diagnosis, right? And cervical cancer carcinoma can be easily differentiated on histology most of the times. And hence, you have histological evidence is there. But if in cases like cases where histology is not available, yeah, it can be tricky to differentiate endometrial versus cervical if it involves both uterus and cervix.
Great, great. All right, moving on to next question. Any criteria for detecting lymph node metastasis in cervical and endometrial cancer?
Again, there is absolute size criteria that we use
Right,
8
right.
millimeters, 10 millimeters, but also we look at the morphology, similar to the rectal, a lot of work is done in the rectal cancer staging of the lymph nodes, morphological criteria, we have, whether the lymph node is round in shape, or if there is any internal, heterogeneous signal in form of, T2 hyperintensity or necrosis or outline of the lymph node, if there are any speculated outline margins. So those are the criteria we use. Lymph node staging on imaging is really difficult, especially anatomical imaging, whether CT or MR. But with the MR, I think rather than just size criteria, we rely on morphological criteria in determining whether there is actual metastasis or not.
Right, right. Thank you. I think the next question was answered on your previous questions, actually. Endometrial carcinoma versus cervical carcinoma, when the mass occupies both cavities, how to differentiate? I think that's partially what you
Yeah.
said on the prior answers. Okay. Next question. Most of the time, we do not get the histopathology or even know if there is a cancer positive endometrium. Say that you just say rule out endometrial cancer for postmenopausal hemorrhage. How do you report in these cases?
Yeah, in those cases, if there is no histological diagnosis available, I would not use FIGO staging system. I would
Right.
just describe the findings in terms of, okay, but if you see, a polypid lesion, but of course, you can, if you see that it's extending into the myometrium, you can be confident in most likely indicating that, oh, there is myometrial invasion, and I would suspect strongly that there is, invasive carcinoma, and hence, I would, recommend more sooner further assessment rather than looking at just a, indolent polyp without myometrial invasion. It can be atypical hyperplasia, or it may be a benign polyp as well. So I think we can use, imaging, particularly, looking at, if there's abnormality in the pelvic peritoneum or lymphadenopathy, or looking at the status of the ovary, if there is any abnormality, and myometrial invasion. So again, in those cases, even though we don't give FIGO staging system, but you can help, the similar approach you can take in terms of, is there an invasion? So if so, I'm worried about invasive carcinoma. If there is no invasion, it doesn't mean there is no cancer, but it can be benign polyp as well, and they can, I would indicate the same on my report.
Great, great, great. Thanks. Um, how do you describe invasion of cervical cancer into the region between cervix and bladder and cervix and rectum?
That would be considered parametral. So if there is an invasion, actually anterior. So even though
Right.
parametrum traditionally we think on the side, on the sides of the cervix when you look at the axial, but actually, there is actually a lot of times we do not call that anterior spread between the bladder. It's a great question, really. And then they go in thinking, oh, lateral parametrum is clean, and then unfortunately, pathological, it comes as, positive margins. So it's very important to assess. Great question. Similar to like parametral invasion, traditionally when we think on the right and left side, but it is also on the anterior and posterior side, and we'll use the same principles. Great question. And that's really cause of many surgically positive margins.
Right, right. And an invasion of bladder and rectum would be a metastatic disease, basically, right? That would be
Yeah, it
a
would be local extent.
right,
So there
local,
is
local.
subdivision between the distant disease. But yeah, then if it involves the bladder wall, if there is a mucosal abnormality, then yeah, rectal.
Right,
Yes. Yeah.
right, right, right. Okay. All right. For the recurrence after surgery, do you use endovaginal gel?
Recurrence after surgery. Actually, in our practice, we do use vaginal gel, but I can see there is not much role, in my opinion, of using vaginal gel. Most of the time, recurrence is fairly obvious. Vaginal gel is not going to help. In my only cases where vaginal gel can be useful is actually, the cervical cancer at the ectocervix and then extending into the vaginal canal to differentiate actual involvement of the wall versus it just projecting into the lumen. In those cases also, clinically, it's very easy diagnosis. So for recurrence, I feel like there is probably no need for the gel.
Okay. Thank you. Last question. This is fantastic. I mean, we've got so many questions up here and such a complex topic. You did phenomenal job. Thank you. Last question. Do you have any thoughts on using functional MRI to look for hypoxic area of the tumor, especially in cervical cancer?
Investigational, again, absolutely. There are a lot of studies that are being done, mainly, honestly, looking at the ADC values, particularly for endometrial cancer, and deciding the, aggressive versus non-aggressive subtyping. But there is a lot of scope and work that needs to be done. And dynamic contrast enhanced imaging definitely has a role to play in and has, hopefully, like if we prove consistently that any one particular imaging finding can be associated with a particular histological subtype, can be a value. More so in endometrial, in my opinion, than cervical, because cervical cancer management is not so much on the histological subtype. It's mainly based on the size and parametrial involvement. But for endometrial, I think there can be a lot of scope in predicting the lymphovascular invasion based on the tumor necrosis and also histological subtype.
All right. Thank you, sir. Thank you so much for all your wonderful knowledge disseminating to our attendees here. Great presentation. Really appreciate you doing this for the third time this year and helping most of our radiologists to have a clear picture on this. Really appreciate that. Thank you.
Thank you. Thank you so much, Dr. JP. Pleasure always. Thank you. Bye.
Absolutely. Absolutely. Thank you. Thank you. Bye. All right. All right. So Dr. Dita would be talking about some housekeeping, and she would share a slide for the next presentation. I would thank all the attendees, all the committees, IT committee especially, and all the moderators and speakers uh, for making it a grand success. Thank you.
Thank you so much, JP, for moderating the session. So, yeah, you can leave or you can stay, and I'm just like gonna share a bit about AREP and our next session. So, if the participant has a problem with IT, you may contact to arep2025.it@gmail. And then if you have like a suggestion for topics, you can contact Dr. Wind with her email here. And also, if you have like a general inquiries about this program, you may contact to Dr. Terpening. It's selenat.terpening at advocatehealth.org. And for our next future session, it will be on October 5th. 2025 at the same date and at the same time with the topic Introduction to Vascular and Interventional Radiology with the speaker Dr. Ochmanek from University of New Mexico. And thank you very much for joining the session and have a great day. Thank you. Bye-bye.
Bye-bye, Dr. Dita.
Thank you.
Yeah.
Bye bye.